had no effect on the SA node. In the example shown here, the morphology of the premature ectopic is consistent with an origin in the ventricles. We would predict that it will have had no effect on the sinus node. Before the ectopic, there were approximately 4 large squares between P waves. We would therefore expect the next sinus discharge to occur at this point. Indeed it did. However, note that it was not transmitted into the ventricles, as it arrived at the junctional region at a time when the conducting system was still refractory to transmission. Also, in this particular example, as the sinus discharge occurred during ventricular repolarization, it is buried within the T wave associated with the ectopic and is not visible on the ECG readout. We would still predict that the next sinus discharge would occur at this point, a further 4 squares on. This is indeed the case. So the P wave following the ectopic occurs at a predictable point on the readout, which is a simple multiple of the preceding P wave interval. Also note that with 4 squares between all subsequent OR waves, the heart rate is the same as that preceding the ectopic. As expected, this is a compensatory pause and supports the conclusion that this ectopic originated in the ventricles. In contrast to ventricular ectopics, discharge from an atrial ectopic will usually result in depolarization of the cells of the SA node, temporarily suppressing their discharge. The SA node recovers its function after a pause of variable duration. As the duration of recovery is variable, the timing of the next P wave is not predictable. The next sinus discharge does not occur at a simple multiple of the P to P wave interval preceding the ectopic. Premature depolarization of the SA node also has a broader effect on its function and may reset its inherent rate of spontaneous depolarization, leading to a different heart rate, either faster or slower, following the ectopic. A pause with these characteristics is termed a non-compensatory pause. Before we summarize the material contained in this video, there are a number of other features of the atrial ectopic worth noting at this point. Firstly, in this particular example, the ectopic discharge has originated low in the atrial cavity, and the bulk of atrial depolarization is spreading upwards. The ectopic P wave is therefore negative in the inferior leads, illustrated here in the rhythm strip, lead 2, reflecting an abnormal P wave axis. You may also have noticed that compared to the normal sinus beat, the PR interval is shortened in the ectopic. This reflects the fact that in this particular case, atrial depolarization has arisen from a focus closer to the AV node than the sinoatrial node. The time taken to reach the AV node is therefore reduced, and the PR interval associated with the ectopic is shortened accordingly. You will see shortly that precisely this type of analysis can help us determine the site of origin of arrhythmias. So, premature ectopic beats can originate from sites of enhanced automaticity in the atria or ventricles. Both occur early, that is, before the next expected sinus beat. Atrial ectopics are transmitted into both branches of the ventricular conducting system and therefore are associated with a normal QRS complex. Atrial ectopics are usually associated with a non-compensatory pause. In contrast, ventricular ectopics are generated in the ventricular wall or a component of the conducting system, and must travel at least in part through the slower conducting ventricular muscle. Consequently, they are associated with broad QRS complexes, and deranged repolarization results in a non-concordant T wave. In addition, ventricular ectopics are usually followed by a compensatory pause.